Welcome everyone. Glad you guys could join us for this. We're really excited to present this topic to you guys. The topic of the presentation is how to implement an effective concussion management program meant for healthcare professionals, particularly physical therapists, athletic trainers, and doctors of chiropractic. The outline for today's topic is going to cover some stuff on pathophysiology for acute concussion injuries, some biomechanics around injury, how much force does it take to cause a concussion injury, and then what are the implications for other tissues within the body. We're going to talk also about the Berlin Consensus Statement, which was just happened about a year and a half ago, and it was in Berlin. And so we'll cover that. That's the new kind of worldwide guidelines for concussion. The assessment treatment modalities for acute and chronic concussions. And then we're going to discuss how to kind of build and implement a program at your clinic. Some information about me. I am a sports specialist chiropractor. I did a 2-year postdoctorate fellowship in sports medicine, and at which point I was studying concussion. I did a lot of work with the University of Buffalo concussion management program, and my area of interest was on post-concussion syndrome rehab. So this is an area that I've been studying now for probably 5 or 6 years. I am the head of research at Complete Concussion Management, and I'm also an executive board member with Brain Injury Canada. For those that don't follow me on Instagram, my Instagram handle is @concussion_doc. I always post some updated studies on there and some other good content for you guys, so if you're interested, give me a follow. So why are we doing this webinar? This was an idea that we had in speaking with a lot of the physical therapists around the world. And really what it came down to is that concussions are obviously increasing at such an exponential rate. There's a lot of these injuries happening in professional sports, but also at the amateur level, school-based sports, etc. And patients really need to get appropriate treatment for concussion. The evidence now is supporting more kind of rehabilitative type management, and it's really unfortunate because a lot of therapists don't really realize the extent of the power that they have to treat concussion injuries. Really, a lot of the skill sets that therapists have are the best treatments for concussion, and concussion is not covered on most curriculum. So most physical therapy programs, most chiropractic programs, even most medical programs don't really talk a lot about concussion. So a lot of the healthcare professionals that are out there don't really have a lot of training in this area. And like I said before, a lot of the evidence for concussion treatment is based on rehabilitation. Medications have been shown to really not be that effective for treating even the symptoms of concussion. However, a lot of the rehab practices such as visual, vestibular, and a lot of stuff we're going to talk about today is and are the best treatments for concussion. And like I said before, many therapists don't realize that you guys have such a skill set that can help so many people. And so we're just trying to kind of bring that knowledge your way. So let's get into it. This will only cover the tip of the iceberg, and what I will encourage you, if anyone is really interested in treating concussion patients, make sure you get additional education and training beyond this, and you're going to see kind of just the kind of the surface level in terms of program implementation, a lot of the research that's out there, but you will likely require much more additional training in order to kind of tackle this topic. So let's get into it here. The brain is organized kind of in this fashion. So what we have here is gray matter, which is this layer, which is the outer cortex of the brain, and that's where all the cell bodies are contained. And then you have white matter, which is the deeper structure of the brain, and it's white because these axons are lined with myelin, which is a fat cell. And then you have kind of deeper gray matter where you have synapses with more cell bodies, and that's kind of how the structure of the brain works. Now, interestingly, concussion used to be thought of as a coup contra coup injury, and I'm sure many therapists have actually learned this term, coup contra coup. But what that used to be was they thought that concussion happened when the brain hit the inside of the skull and bounced back and hit the other side of the skull, and creating a kind of a bruising of the outer gray matter of the brain. What we're starting to realize now is that concussion is more of a stretch or shear injury. And the reason is because the two layers of tissues, and I'll just go back to this picture, these two layers of tissues, you got gray matter here, white matter here, they're actually different densities. So they accelerate and decelerate at different rates. So if you picture the brain being almost a plate of jello, and if it were to jiggle and shake, the two layers of tissues are going to jiggle and shake at different rates, and they're actually going to pull apart, creating a stretching of these axons. So concussion used to be thought of this coup contra coup injury and this injury to the outer gray matter, but in fact it's now believed to be more of a deeper white matter injury due to the stretching and shearing mechanisms that happen. So this is a good video here just to kind of show you guys. It's almost a fluid wave, so you can see the impact, and you see how the brain has that kind of fluid wave to it. Now you can picture each individual axon fiber being stretched and pulled away. Here's a good video that I found, and this was actually a video of a lawyer discussing motor vehicle accidents, but on YouTube it was the best video I could find. You might see the guy's hands kind of over here and sneaking into this shot. But what you see here is those two layers of tissue. They're going to zoom in here on it. There's the lawyer. And what you see here is upon that impact, you get a little bit of that kind of coup contra coup, but really you can see what's happening here at that junction between white and gray matter is that they're kind of pulling apart and also shearing across each other. This is probably the best video I've found to explain that process, that mechanism. If we zoom in on it, you can see it kind of happening at the microscopic level. And just like that. And the reason that we're starting to realize this is through an imaging technique called diffusion tensor imaging. And you can see here, this right here is the corpus callosum of a healthy brain on the right hand side, and you can see all the projections going out, and there's nice color in there, and this represents the flow of water along axons. So when you have intact axons that don't have any kind of damage to them, you can see the difference here where you have this dark spot in the posterior aspect of the corpus callosum. That's actually the most frequent spot for concussion injuries they found in a lot of these studies. This is what a diffusion tensor scan looks like if you were to do the whole brain. This is a newer technology. There's a lot of kind of unknowns with this technology, which is why I didn't really discuss it much in this presentation, but just wanted to show you kind of the new evidence that's emerging and the new science and techniques that are coming out in concussion. So what happens when that brain has that stretching and that shearing of those cells? Well, concussion actually has two phases to it, and that stretching and shearing creates a mechanical deformation of the axonal membrane. So if you can picture like the porous membrane channels of the axon, when that brain undergoes that acceleration and deceleration and has that mechanical stretching and shearing, that membrane is going to deform. Well, if we remember back to our intro physiology classes, you have this concentration gradient. So you have high potassium inside the cell, high calcium, high sodium outside the cell. So they always want to go down their concentration gradient. And if given the opportunity, they're going to go like that. So you have, once this mechanical stretching happens and these porous membranes open up and you get this gap that happens, you're going to get all this potassium is going to leave, okay? All this calcium and sodium is going to come rushing in. Well, what is that going to do? It's going to create a depolarization, and you're going to start to get action potentials. So in the simplest form, all a concussion is millions of brain cells that get stimulated with an impact all at the same time, and the brain undergoes this massive depolarization. You get tons of action potentials happening at the same time. If you can kind of picture the idea behind a seizure almost, it's kind of a similar mechanism to that. So you get action potentials, and what each of those action potentials is going to do is release an excitatory amino acid, meaning a neurotransmitter. And the one most often implicated in concussion is the excitatory amino acid glutamate. Glutamate does two things. So once you get those action potentials, you get a release of glutamate. It's going to obviously cause more action potentials at the neurons down the line. But what it also does is it activates these surface receptors called NMDA receptors. And essentially what these are is calcium channels. So if you go back to this, you can see calcium already is going to get in with that initial insult because it has that concentration gradient wanting inside the cell. But also that release of glutamate is going to activate these NMDA receptors, and you're going to get more calcium flooding into the cell as a result. Calcium coming into the cell is the biggest problem that we have with concussions. And I say this all the time, if we could find a way to somehow stop the flow of calcium or at least limit the flow of calcium, concussions wouldn't have the same degree of impairment that they currently do. So the initial signs and symptoms, this influx of, this action potential bombardment could cause loss of consciousness, could cause seizures. Sometimes the person is just kind of vacantly staring. And if you can picture so much brain activity happening at the same time, that they can't really focus and things aren't really going in the right direction in terms of their neural flow. Everything's just going crazy. And so you might be speaking to them, they might be looking right at you, but it's literally going in one ear and out the other because it's not going through the proper channels. And so they'll have this vacant stare and they'll be extremely confused. It could cause disorientation, slurred speech, incoordination, any of these things. It's a very short duration phase, this excitatory phase, but I'll show you a couple of videos here. So this is a skateboarder. And you can see him fall, and you can almost see it start. So this is kind of that post-traumatic seizure that's happening right now, and he almost kind of fires up like that. Now this is a very rare occurrence in concussion. It does happen. But obviously a very scary situation. But that's really just the series of action potentials starting to kind of take hold and build, and that's the excitatory phase. It can also have this effect. So this is a loss of consciousness. You can see him land here. Now he goes into what's called a fencing response. So his arms are up. So that's a clear indication that there's been a loss of consciousness. It's also an indication that there was some brainstem involvement in the injury. You can see the helmet whipped his head back there, and there's the fencing response. So that phase could cause loss of consciousness, or it could just cause impaired balance, such as this case. So this one here, and interestingly, when they slow this down, this was a shoulder-to-shoulder hit, but you can see how off balance he is. That's because there's so much activity in the brain that they're not able to see where, what's up, what's sideways, and it's not getting the right messages. So they end up falling or being significantly off balance. So shoulder to shoulder hit, didn't even hit him in the head, which comes down to the biomechanics of injury. But you can see off balance, falls, but then able to get up and skate off with no incident. So you can see how quick that initial excitation phase can be. So let's recap where we are. So first we had potassium leaving the cell because of the mechanical stretching of the membrane, which created action potentials, the release of glutamate, which then caused more action potentials, as well as activation of these NMDA receptors, which allowed more calcium to come flooding into the cell. So basically what we've created here within the cell is an ion imbalance. In order for cells to work properly, they have to have that proper concentration gradient restored. However, they don't have that right now. So what we have to do is activate the sodium-potassium pump. And remember, this requires ATP to do this because we have to pump sodium out of the cell against its concentration gradient, and we have to pump potassium back into the cell against its concentration gradient. So this is active transport and requires a lot of ATP. So this pump in normal healthy people burns about 2/3 of our ATP. So it's always extremely active, and after a concussion injury, that activation kicks up even further. So now you start burning a heck of a lot more ATP, okay? So energy. Calcium then has gotten into our mitochondria because it has a high affinity for mitochondria, and this is where the problems really start. Because calcium gets into the mitochondria, it renders our oxidative metabolism basically dysfunctional. So now we have to rely on anaerobic means for our ATP production. So that is actually 9 times less efficient of a system than our oxidative metabolism. So now we require a lot more ATP, however, we're making 9 times less. 34 to 38 ATP with oxidative metabolism, that's not working. So now we're down to 4 ATP per molecule of glucose. So the increased demand for glucose, therefore we have an increased demand for blood flow. The problem is blood flow also decreases into the brain immediately following injury by as much as 50% in some animal studies. Unfortunately, we can't get into all the mechanisms of blood flow in this. So here's what we have. Ultimately, what we're left with is this: increased demand for ATP, decreased production, and an overall energy crisis. So this is what it looks like. This is in an animal study, and what they did basically is they gave animals a concussion, and then they monitored their ATP levels at different time points after the injury. And you can see here, 1 minute there's already a drop, 10 minutes, 30 minutes, 2 hours we hit significant difference. That's what this little star means. 6 hours we hit the peak low. 15 hours later, still significantly different. 24 hours, 48 hours, and 120 hours, which is 5 days. There's no more significant difference. You can see they're not quite back up to their baseline level, but the full recovery for an animal is considered kind of that 5-day mark. Now, humans go through the same process, but it's not 5 days. It's actually 22 to 30 days, and I'll show you that. The issue and the big concern over concussions is that during this phase where these energy levels are low, this is where the brain is extremely vulnerable to any additional impacts, where you can actually get a concussion with less force. And those secondary concussions can add up to what's called second impact syndrome, and that's really where you get these potentially fatal brain injuries with multiple trauma. So here's the difference between mild traumatic brain injury, which is what concussion is, versus a severe traumatic brain injury. So in a mild traumatic brain injury, concussion, you have a 20% reduction in your ATP levels. The mitochondria are damaged, but not irreversibly. They can come back online. And they still have some phosphorylating capacity. So they're not completely shut down, but they are reduced significantly. So this reversible energy deficit in concussion. Severe brain injury, we have a 50% reduction in ATP, which creates significant alteration in the ability for the mitochondria to phosphorylate and create oxygen, and these damages are potentially permanent. What we do know about 2 concussions is that if they occur in close temporal proximity, they can lead to the same irreversible damage that we see with severe TBI. So this is really the concern around concussion. It's not necessarily having a concussion, it's having multiple concussions in a short period of time. Here's another awesome study. Again, this is an animal model, and this will highlight the point that I just made. So this graph right here is a little bit confusing to understand, but I'll walk you through it. On the left-hand side here, we have the control group. So this group didn't have a concussion at all, and you can see what their ATP levels are. Now, NAA is essentially an ATP correlate. So in this case, they measured NAA, but just consider this to be ATP. So here's the control group, and then we have one single concussion in the middle, and then over here we have a severe traumatic brain injury. So you can see the difference. From here to here, we have about a 20% reduction in our ATP levels. You can see over here, we have about a 50% reduction in our ATP levels. Now, what the researchers wanted to do is they wanted to see if we were to give this group of animals here that had a single concussion, if we were to give them a second concussion at different time points during the recovery, what would that do? And so if they waited the full 5 days, this is the group right here. And you can see here, these 2 stars represent that these 2 groups were not significantly different from one another. Meaning that if you got a concussion and you fully recovered, remember the animal recovery is 5 days, and you got a second concussion, there was no additive or cumulative effect. The 2 injuries actually happened and acted as independent events. However, when they hit the animals at day 3, same force, same mechanism, you could see here that those 2 groups were not significantly different from one another. Meaning that if you get a concussion, you don't fully recover, and you get another one, you can end up with some pretty significant damage. And in fact, 10% of the animals in each one of these groups died as a result of that injury. So the big thing for concussion is recovery. And it's not necessarily symptomatic recovery, as we'll see, it's actually metabolic recovery. So this is the human study. And again, we're looking at NAA. So NAA is a correlate of ATP. We can't actually directly measure ATP in humans. So we have this molecule called NAA that they measure with a technology called magnetic resonance spectroscopy. And you can see that they look at different ratios. Let's just follow the black bars just so that it's easy for us to do so. So here's a control group, no concussions. This is 3 days after injury. We can see that there's a significant difference from the control group. 15 days after injury, still significantly different than the control group. 22 days after injury, still significantly different than the control group. And then not until day 30, we lose that single star and we're back up to our baseline levels. So somewhere, because they only measured them between 22, they didn't measure them between 22 and 30 days. We don't know at which point, maybe it was day 25, maybe it was day 26 that they actually achieved full recovery. But what we do know is that by day 22, there was still a significant difference between them and controls. So if we extrapolate that, and what we know about the animal studies is that during that period, the brain is extremely vulnerable to additional trauma. Well, what are we doing with our concussion patients if we're clearing them after a mere 7 days? Every single patient in this study was asymptomatic by day 8. Most of the people in this study were asymptomatic by day 3. There was a couple people that were asymptomatic at day 8, and that was it. So you can see here that symptoms don't reflect the recovery of the brain. And relying on a symptom-based approach to make your return to play decisions is the wrong way to do it. This right here is a study that looked at multiple concussions within various time periods. So going back to this one here, this same group in Italy had people that were involved in this type of study that decided they didn't want to wait the full 30 days. They wanted to return to their sport sooner. And so what we end up here is a case series of individuals that left the study early and got a second concussion. And we can get a pretty good idea of what happens to them afterwards. So here's the subjects here. We have boxing, rugby, soccer, kickboxing, boxing. All subjects were male. You can see their ages here on the side. Symptoms after the first concussion, 1 or 2 symptoms, headache, amnesia, etc. And then you can see the duration. Typical symptom duration, 3 days, 4 days, 8 days, 7 days, 8 days, 5 days. Then they had a second concussion, 10 days after the first, 9 days after the first, 18 days after the first, 16 days, 21, or 19 days. Now, here's their second concussion. Symptom number obviously increases. And look at the duration of their symptoms. What was a 3-day injury now turns into a 52-day symptomatic recovery. 59 days, 44, 35, 24, 33. And you can see that basically the longer amount of time they had between their injuries, the less length of recovery they had with the second injury. So you can see here, this one had the most amount. They also had the least amount of days for their second recovery. And then you see this right here. This is NAA normalization. So if we go back again, we can see this is NAA normalization after 1 concussion, 30 days. But after 2 concussions, NAA didn't normalize till 120 days. 120 days, 90 days, 90 days, 60 days, and 90 days. So not only are you going to have a greater duration of symptoms after that concussion, but now the vulnerability period goes from what would be 22 to 30 days, somewhere in there, and ends up now being 3 to 4 months. So now what happens to the hockey player, the football player, the rugby player, the soccer player that goes back after their symptoms are recovered from this? So now they've been out for 2 months, their symptoms are gone, so then we clear them, but they still have another 60 days of vulnerability here. And that's where things, I think, start to get a little bit dicey for concussion patients. So the question I always pose to people when I educate them is, do we have a concussion problem or do we have a concussion management problem? Is all of this stuff that's going on right now in professional sports leagues and everything else, is that due to the fact that people had some concussions, or is that due to the fact that people had some concussions that they weren't properly recovered from and now they end up with these chronic neurodegenerative condition because we're injuring them shorter and shorter distances each time, and things are compounding and now becoming additive? And this actually made it into the Berlin consensus statement. So this was one of the systematic reviews that was used for Berlin. And this is what they said. What is the physiologic time to recovery after concussion? Because of these assessment challenges and the potential for repeat injuries when returning patients to sports too early, clinicians are frequently left in a quandary with limited data to guide decision making. Some recent studies suggest that physiologic time of recovery may outlast the time for clinical recovery. The consequences of this are uncertain, but one possibility is that athletes may be exposed to additional risk by returning to play while there is ongoing brain dysfunction. Possible hazards may include repeat injury, prolonged symptoms, increased risk of musculoskeletal injury, more severe physiologic dysfunction, or increased risk for neurodegenerative diseases. So we're starting to smarten up about this. And this is really what we need to do. This is typically when people are cleared right now. Once they feel that they're clinically recovered, most of the time, their physician or sports medicine specialist will clear them to return to play based on a symptom-based approach. We need to be thinking more like this. We need to have full recovery from a physiologic standpoint and a clinical standpoint. The problem is, as you saw, symptoms are a very poor indicator of recovery. So we need objective measures, and this is where the idea behind having some preseason metrics comes in. So balance, reaction time, cognitive ability, memory, visual processing, physical capacity, etc. And what we see from some of the studies that have been done on this is that even when athletes are asymptomatic, so here's one, for example, using neurocognitive testing, at the asymptomatic time point, 38% of concussed athletes continue to demonstrate neurocognitive impairment on at least one impact variable. The exclusive use of symptom reports in making return to play decisions is not advised. A multifaceted approach to concussion assessment that includes evaluation of a myriad of functions is warranted. So a lot of people are just doing the computer-based testing, and what the research is showing on this is that that is not sufficient. So a lot of these tools on their own have test-retest reliability issues, and essentially the consensus is that we should not be using them as the sole determinant of our clinical decision making, and we should be using a multifaceted approach. And here's some kind of studies to back that point up. So clinical utility of impact assessments for post-concussion return to play counseling. We conclude that the empirical evidence does not support the use of impact testing for determining the time of post-concussion return to play. Test-retest reliability of computerized concussion assessment programs. 3 contemporary computer-based concussion assessment programs evidence low to moderate test-retest reliability coefficients. Impact test-retest reliability. Again, our current data support a multifaceted approach to concussion assessment using clinical examinations, symptom reports, cognitive testing, and balance assessment. The heterogeneity of concussion, meaning how multifaceted the injury is and affects balance, reaction time, vision, all this different stuff, should all be tested. So the heterogeneity of concussion supports the movement towards multimodal concussion assessment, premised on the view that a single domain-specific outcome measure, such as cognition or balance, are insufficient for detecting the full spectrum of concussion sequelae. The multidimensional assessment approach recognizes this complexity and integrates outcome measures across multiple domains of functioning. And this is really what we've done with our program, and if you're going to start a program, you should do as well, is don't just go into, a school or a sports organization and provide them with the neurocognitive test. It's insufficient. Really, as good, prudent practitioners, if you are going to be managing concussions, we need to try and make sure that we have as multifaceted approach as we can so that we can try to pick up as much dysfunction as we can so that we're not clearing people based purely on symptoms. And we see this in some of these studies that have been done. So this one here used a multimodal clinical assessment approach, and look at the results here. Recovery time across all outcomes was between 21 and 28 days. So see what that automatically did? If we go back to the kind of Berlin return to learn, return to play strategy, you can be cleared within 7 days of having your injury. But when you throw some objectivity in there and have a multifaceted approach, we see that these athletes aren't being cleared until that 3 to 4 week mark, which is exactly where we want them. When recommended, the comprehensive approach is used for concussion assessment. Recovery time for sports concussion is approximately 3 to 4 weeks, which is longer than the commonly reported 7 to 14 days. Sports medicine clinicians should use a variety of complementing assessment tools to capture the heterogeneity of sports-related concussion. So that there is on baseline testing. So again, there is so much more to these topics than what we're able to cover today, but I want you guys to know that if you're just using a computer-based approach, or even if you're just using the SCAT, the issues with the SCAT, which is the Sideline or Sport Concussion Assessment Tool, which was developed in Berlin, is that it's a great sideline tool in order to give you a little bit of objectivity, but if you don't know their pre-injury status, it doesn't really, tell you much. The other side of the coin is that SCAT results typically normalize 3 to 4 days after injury. So those results in terms of your balance and your memory and all that stuff will be back to normal basically before the symptoms go away. So how much does that really help you when you're trying to make a return to play decision? Well, not a whole lot. And with impact or any of these other neurocognitive testing, if that's all you're doing and you don't have other tools to utilize as part of your program, you're going to miss a lot of the things. And due to the test-retest reliability issues, probably more than you would like as a clinician. So we're going to get into acute injury management, return to learn, work, and play. So this is, I'm not sure how many clinicians that are out there that are doing this right now, but this is a huge component of what physical therapists, ATs, and chiros can lend to this picture. So the clinical assessment should include a comprehensive history, detailed neurological exam, including a thorough assessment of mental status, cognitive functioning, sleep, wake disturbance, ocular function, vestibular function, gait, and balance. And again, this is what is recommended by the international consensus from Berlin. Determine whether or not there has been an improvement or deterioration since the time of injury. You may need to ask the parents, the coaches, the teammates, etc. How have they been? Are they getting worse? Are they getting better? Because that can tell you a lot, because really what you want to do is determine the need for emergent neuroimaging to exclude a more severe brain injury. The concern isn't necessarily concussion. The concern is that they have something worse than a concussion, such as a bleed or a skull fracture or increasing pressure inside their brain. And there's some telltale signs for this that you should be aware of. They should be in to see someone with training within 24 to 48 hours. And a lot of the evidence around persistent symptoms demonstrates that if they're in to see somebody with training, regardless of the professional designation of the person, but somebody that has experience and training in concussion, can really change the outcome of persistent symptoms. We can actually make people better just by providing them the right education, the right steps. Concussion research is changing at such an alarming rate that it takes a lot of time to try and stay up to date with all the evidence that's coming out. Like, for example, we update our protocols at Complete Concussion Management. We update them every month, and that's how fast this stuff is changing. So they should be in to see somebody quickly so that they can provide them with the right education, the right information, and that will help the recovery process. Really what the point of your initial assessment is, and I said this already, but is to rule out more serious injury. So you're looking for the red flags. Initial assessment, history, symptoms at the time of impact. Was there a loss of consciousness? Is there any vomiting? These are some of those red flag issues you should be aware of. If they've had vomiting repeatedly, they should be going to the hospital to get a CT scan. If they're displaying signs of worsening condition, increasing headache, balance impairments, they're falling all over the place, they're slurring their speech, those are all indications that they should be going to the hospital to get a CT scan just to rule out any type of increased risk for bleeding or anything else. The diagnostic criteria for concussion is pretty straightforward. If they had any type of mechanism of injury, meaning any type of impact where their body was accelerated or decelerated, and they had any symptoms following the injury, then this is enough to diagnose with a concussion. You should ask them also the symptoms that they're experiencing right now. The outcome measure we use is from the SCAT. It's called the Post-Concussion Symptom Scale, and it's simply 22 symptoms rated 0 to 6. 6 being the most severe, 0 being none at all. And you go down the list and have the athlete rank those symptoms. Do you need a baseline to make your diagnosis? And this is kind of the confusing part for a lot of people, because they'll want to do something with the patient right away. They'll want to run them through their baseline. If they have a SCAT on them, they'll want to repeat that SCAT. But ultimately, the decision is still a clinical decision. The baseline test becomes more valuable actually at the back end. Once their symptoms have gone and you're trying to make a return to play decision, that's when your baseline test, if it's a good high quality one that has multiple domains, can be the most effective. Right now, to make your diagnosis, most of the time it's not needed. Did they get hit? Yes. Do they have symptoms? Yes. They have a concussion. putting them through, having them sit there and do a computer test for a half hour is only going to reaffirm what you already know, and is really not going to help their situation for the most part. Because concussion performs no differently than orthopedic injuries in the immediate setting on cognitive measures, right? So even just any injury in general will affect your cognitive ability. Pain, post-traumatic stress, all affect neurocognitive scores. So just because somebody shows deficits on their neurocognitive testing doesn't necessarily give you any additional information about concussion. It just tells you that they may be in pain. Once you've established your diagnosis, now you have to just kind of give the patient the information to be able to manage their symptoms and get back to their regular life. So return to learn or even work, you can apply this to the work setting. It's very similar. Again, this is from the Berlin Consensus Statement. But you see there's multiple stages here for recovery. And what you're doing is you're just guiding the athlete through these stages. A lot of this time is self-monitored. You just tell them what to look for. And if they have any symptoms at any one of these stages, they just go back to the previous stage. They don't have to start it all over again. They just go back to the previous stage. So what we used to say is stage 1 was rest. You're not allowed to do anything. You're going to rest. You're going to shut off your computer. You're not going to go on your phone. You're not going to do anything. And what we're finding now is that rest actually makes people worse if you do it for more than 2 or 3 days. So you want to kind of shut it down a little bit cognitively. You want to take it easy, but you don't have to be in a dark room. You don't have to avoid all activity whatsoever. I still encourage people to go for walks, to do any type of reading, screen time, anything, provided it's not provoking their symptoms. If it is provoking their symptoms, well, then they just avoid that for a few days and then try it again. So what you want here is basically symptom-limited activity. So typical activities: reading, texting, screen time. As long as they're okay with it and it doesn't increase their symptoms, they are more than okay to do this. Dark rooms will make people worse. Bed rest will make people worse. Please do not advise your patients to do this anymore, because I see the back end of it and it's not good. Once they're okay at home and they're able to do kind of 30 to 40 minutes of activity at home and getting into homework and things like that, then they can go into half days of school. You can give them some academic accommodations depending on their issues. Some people have difficulty with music class, gym class, that type of stuff. So you want them avoiding those activities, and just gradually kind of get them back into increasing the workload that they're doing at school. Start with half days. When they're good with half days, then you can send them to full days. Each one of these stages should be separated by at least 24 hours. So they shouldn't just go from here right to here. It should be separated by at least 24 hours. And if they have symptoms at any one of these stages, like if they're getting symptomatic with full days, just bring them back to part days, halftime days, and go from there. And just kind of 2 steps forward, 1 step back sometimes, but you're always trying to progress them forward and push them back into activity, because ultimately that will be better for them. Getting into return to play. So if they're just a student and they're not an athlete, you can just go through the return to learn and get them back into school. And once they're asymptomatic, then they're discharged. But if they're an athlete, then you want to also do return to play. So the update from Berlin again was the removal of absolute rest. So they're going to do again symptom limited activity is stage 1, daily activities that do not provoke symptoms. Stage 2 is light aerobic exercise. So I usually bring them into the clinic for this. We do the Buffalo treadmill test for those that are familiar with it. We'll bring them in and run the Buffalo treadmill test at this stage so that it's monitored. We put a heart rate monitor on them and see how they respond to increasing physiologic load, seeing how their blood flow mechanisms are, because if we're going to return them to sport, we want to make sure that their blood flow mechanisms are there and they're not going to be provoking symptoms, making themselves worse. So we'll bring them in for the Buffalo treadmill test. If they pass, then we allow them to go back into sport-specific exercise, which typically involves just going to practice, and it has to be non-contact. So they do this one practice, then the next one is non-contact training drills, and this is just simply another practice, but you have harder training drills, get into more kind of team-based stuff, and then getting into also resistance training. So they can start doing kind of that dry land training, getting into the weight room again, lifting weights and not doing anything with contact still. So they're still avoiding contact. Once they've had those 2 practices, then they get cleared, and this is the medical clearance spot that we'll talk about. They can then go back into full contact practice. So if they're a soccer player, they can start getting headers after. If they're a football player, they can start doing some light contact in practice. And then you have a full return to sport and full game play. So you can see here that each one of these has to be separated by 24 hours. And so if you were just going to follow this return to learn, return to play process, you could have the athlete done in 6 days and they could be playing again on the 6th day. Well, given what we know about metabolic recovery, I don't think this is the right approach. We should be really trying to pull the athletes back, slow the process down. Yes, there's 6 stages, but our goal shouldn't be to get them back on the field in 6. Our goal should be to try to get them as close to that 21 to 30 as we can in order to decrease the likelihood of getting a second impact syndrome. And you can see here, and this is where therapy becomes extremely important. If symptoms are persistent, more than 10 to 14 days, the athlete should be referred to a healthcare professional who is an expert in the management of concussion. And the reason is because what we're finding is that rehabilitation initiated earlier on is more beneficial. And I'll show you some studies coming up here, but that first 10 to 14 days, if they're still symptomatic, they should be getting rehab from a trained therapist. And I'll show you guys all that stuff as we go forward here. So here's a systematic review that was looking at rest and rehab just to show you how the times have changed and moved away from rest. A brief period, 24 to 48 hours, of cognitive and physical rest is appropriate for most patients. Following this, patients should be encouraged to gradually increase activity. The exact amount and duration of rest are not yet well defined and require further investigation. The data supports interventions including cervical and vestibular rehabilitation and multifaceted collaborative care. Closely monitored subsymptom threshold, submaximal exercise may be of benefit. So again, you see how they're chopping this down now, 24 to 48 hours. We used to have people wait and rest until their symptoms went away. Now we're saying, no. 24 to 48 hours and that's it, and let's get you doing whatever you can do. And again, what we're looking for is symptom exacerbation. Anything they can do without provoking their symptoms is okay. So some people do it like this. I'm not a fan of doing it this way, but what they'll do is they'll run return to learn and work and return to sport at the same time. The only problem is what can happen is that you could be on symptom-limited activities at home. Oh, I can't go to school, I can't do any cognitive activities, but I'm fully cleared to go back to my sport. And the recent kind of systematic review that was looking at pediatrics said that children and adolescents should not return to sport until they have successfully returned to school. And this is how we've been running our return to learn, work, and play process at Complete Concussion Management for the past kind of 4 years. And we'll do the same type of process, but what we've done essentially is take return to learn and just put it in front of return to play. So now automatically we're increasing the number of steps that the patient has to go through. So instead of being able to pass through the steps really quickly and be done by step 6, we've added 10 steps now. So now they go through, return to learn. As soon as they're back in full school, then we put them on the Buffalo treadmill test. Then if they pass that, we allow them to go back to their sport and with certain restrictions, light activity. Then we get into non-contact training drills. Then when they come back in for their medical clearance, we actually put them through the Chicago Blackhawks test. So it's a sport-specific physical exertion test, and we actually just did a study with the Chicago Blackhawks, and we have it right now in for submission with the physician in sports medicine. And what we found, I'm actually presenting this also at the North American Brain Injury Society conference in Houston in 2 weeks. What we found with this is that patients that went through this process, they would be asymptomatic with rest, asymptomatic with light cognitive activity, asymptomatic with school. They would pass the Buffalo treadmill test. They would go to 2 practices and be asymptomatic. 15% of them would fail the Chicago Blackhawks test. So that tells you right there that there's physiologic mechanisms that still haven't recovered yet. And most of these people are 2 to 3 weeks out. Well, if you're just going to test somebody or you're just going to clear somebody based on their self-reported symptoms at rest, you're going to miss at least that 15% that we're finding that are probably being cleared far too soon. And then after, if they pass their Chicago Blackhawks test, we then take them and put them through full battery of physical and cognitive testing, including balance. We use force plates, reaction time. We use some visual tracking and processing speed testing, and a whole battery of tests. I think we have 11 tests in our battery, but this gives us a nice comprehensive viewpoint of, is this athlete actually recovered, actually ready to return to the playing field? If yes, we provide medical clearance, allow them to go to their full practice, and if they're okay with full practice, they then go on to full game play. I hope that wasn't too fast for everyone. We also have an app that we use. I'll just kind of quickly go over this, but basically what we've done is connected our system with it so that athletes can be monitored by a coach. So if you're a coach, you can see your whole team and you can see what stage they're on and what they're allowed to do. So this connects with our kind of EMR system for all of our clinics, which allows things to stay nice and together. We also have one for athletes as well. They can report their symptoms every day. So even when they're not in the clinic, you can kind of have an idea of how they're recovering, what activities they're doing, and what's bothering them, what's not bothering them. So moving on now from acute concussion management. I know I'm flying through. I'm trying to give you guys as much information as I can in a short period of time. But moving on from acute to post-concussion syndrome, so PCS. They used to say that only 10 to 15% of patients would go on to have post-concussion syndrome. We're now finding out that it's a heck of a lot more than that. 33%, 48%, 21%, 36%. So you're looking to between 30 to 50% of patients having symptoms that last longer than 4 weeks. And I think this is getting worse and worse. And I think the reason is due to inefficient management, because we've always been telling people to go into dark rooms and things like that, which I think is prolonging symptoms. And I also think that it's not getting the right information from the right practitioner that's going to give the patient the best outcomes in terms of their recovery. So PCS is post-concussion syndrome. The definition of it, depending on which one you use, the most common was the ICD-10 criteria, which judges it as any symptoms lasting longer than 4 weeks is considered post-concussion syndrome. Treatment for PCS should start within 10 to 14 days. And like I said before, when you're doing the return to learn, return to play stuff, if I have any patient that hits that 10 to 14 day mark and they're still having symptoms, I'm going in, okay, why do you have symptoms? I'm going to find out, is this a physiologic issue? Is this a vestibular issue? Is this a visual issue? Is this a cervical spine issue? And try to figure out what that is, because the rehab should be initiated at that time point. And if you're a physician listening to this right now, you should be looking for trained therapists in your area to send these patients to, because if you don't get them rehab that early and you're waiting, you'll find that the symptoms will just continue to linger. So we actually start treating people as if they are post-concussion syndrome at 10 to 14 days. Even though by definition they're technically not post-concussion until they're at day 30, we treat them as if they are at day 10 to 14. And we don't really know why. Why do they have symptoms that linger? And we're not really sure, but there's 5 main theories. And I'm going to go into each one of them kind of briefly here. The main theories are, one is a blood flow abnormality. So like we said before in the pathophysiology, when the concussion happens, there's about a 50% reduction in blood flow to the brain. And in some patients, particularly those that have lingering symptoms, those blood flow mechanisms have found to still be impaired in some of them. And so that's called physiologic or a blood flow abnormality. That's like a true kind of brain responsible reason for why people have persistent symptoms. Next is metabolic or inflammatory, visual and or vestibular dysfunction. I pair these together because oftentimes just because someone has dizziness does not mean it's a vestibular issue. It oftentimes, and most often than not, is a visual issue, not necessarily a vestibular issue. Cervical spine dysfunction. I'll get into that topic as well. And then finally, psychological. And I will say this is 100% of the time involved in almost every single concussion or post-concussion syndrome case. And I'll explain all this when we get into it. There's other mechanisms: continued axon dysfunction, white and gray matter volumetric changes. These are things that they're kind of more early stage. There's inconsistent and conflicting evidence on these right now. The good thing about the main theories of PCS is that all of them are treatable 100%. And all of them, except for maybe the psychological, can be treated through physical therapy, chiropractic, athletic therapy, and co-managed with other multidisciplinary professionals for the psychological piece and potentially any other medical issues that may arise. So the treatment for persistent symptoms on the physiologic side for blood flow is actually exercise. So remember, we used to tell people not to exercise at all. Well, a few years ago, a group out of the University of Buffalo started putting people on treadmills and actually encouraging them to exercise in a sub-symptom threshold manner. The trick, however, is doing a specific protocol using the Buffalo treadmill test in order to establish what their particular threshold heart rate is, and then having them exercise at a reduced rate from that heart rate so that you're not provoking symptoms when they're exercising. You're finding out, you're establishing what that threshold is. Do they have a blood flow abnormality or not? And if so, where is it? And then what's the exercise protocol to treat it? And just doing exercise has been found to be extremely beneficial for these patients. So at 2 weeks is when I force people, at our program, we force people onto the treadmill at 2 weeks. So if you're still having symptoms, all right, treadmill test. And here's all the evidence for exercise. So this is one of the first studies that was done. 77% of people with persistent symptoms had a full return to function with only a few weeks of exercise protocol, versus those who didn't exercise, only 20% had a full return. Here's other ones. They even found these blood flow changes improving on fMRI studies. This one here was done in pediatrics. Increased processing speed in adolescents after 7 weeks of exercise. And I mean, the evidence just goes on, and this isn't even a fraction of how much is out there on this topic right now. So exercise is beneficial. We've established this, and it actually made it into the Berlin Consensus. Closely monitored active rehabilitation programs involving controlled sub-symptom threshold, sub-maximal exercise have been shown to be safe and may be of benefit in facilitating recovery. So again, this is something that therapists can and should be doing for all their concussion patients. Theory 2, metabolic or inflammatory. So we talked about that ATP deficit. Well, maybe in some patients, perhaps that ATP deficit lingers beyond that 22 to 30 days, and maybe that's why they have symptoms. So far, the evidence on this, though, hasn't really shown that. It's been a little bit mixed, but for the most part, people with persistent symptoms, their metabolic levels are back up to normal. In certain cases, however, such as the people who never took any time off work and are really kind of go, high-stress jobs, their metabolic levels may remain low. So it really depends on the patient you have, how you're going to approach this particular issue. There's also dietary things that you can do for patients to boost that metabolic level. So things like creatine and whatever else. There's a whole bunch of dietary things. We actually have a 2-hour module as part of our course just on the dietary and supplement recommendations that can help patients with persistent symptoms. 2B is also the inflammatory process. So any type of inflammation in an area is going to create signaling to bring on more inflammation into the area. And a lot of times inflammation can cause a lot of the same type of cognitive impairments and headaches and things like that concussion symptoms can. So maybe it's just an inflammatory response in the brain that is remaining. And again, there's dietary things that can help to kind of squash that. And in fact, we give our patients, even in the acute stage, we give them a dietary plan on day 1 to try and get over this part, like immediately, to try and give them the best chance for success. Theory 3, visual and vestibular dysfunctions. Difficult to tell these ones apart, which is why I include them together. Also, the cervical spine is heavily involved in this mechanism as well. So vision and ocular motor function. So visual diagnoses have been found to be quite common after concussion. Christina Master does a lot of work in this area, and they found that about 70% of patients that are involved in their studies have visual problems following concussion. 51% are accommodative disorders, 49% have convergence dysfunctions, and 29% have saccadic dysfunctions, but really a lot of them have more than one overlapping issue. So a lot of times people with balance impairments and dizziness, oftentimes they're not necessarily a vestibular issue, but they're a visual issue. Vision is one of the most integrated things in our entire in our brain. There's 26 or 30 different processing areas that require kind of visual input, and so it's very likely to be impaired following injury just because of the diffuse nature of concussion and how kind of global it can be. Vestibular issues, dizziness, sensations of being off balance, and motion sensitivity, some of the most commonly reported symptoms. can be due to either central or peripheral vestibular disorders, and also can be the C-spine. Several studies have demonstrated that resolution of these symptoms in chronic patients with vestibular rehab. So again, this is therapy. Therapists that have training in this area, you guys can help a lot of patients with the skill sets that you already have, as long as you learn how they apply to concussion and how everything kind of ties in, which is really the difficult part. This study was very recent. We actually just put it in our December or January monthly research updates. Like I said, we update our protocols every month. So this one is a brand new one. And they found that they were looking at patients with dizziness, and they found that 100% of the patients that were coming in with post-concussion syndrome complaining of dizziness as a primary symptom, 100% of them had ocular motor issues. Only 10% had only ocular motor issues. 46% had vestibular disorders. 83% had cervical dysfunction leading to their dizziness. So again, 100% of the patients had visual and ocular motor issues. So again, if you're only doing vestibular, or if you're only doing one facet, you're not able to kind of combine everything and really, find the true cause of these issues. Theory 4, cervical spine dysfunction. This is probably one of the most overlooked and underappreciated issue, and it's perhaps just my bias as a chiro, but we learn a lot about how this stuff ties in terms of brain function, balance, dizziness, and all that stuff. So I'm going to get into a little bit of that right now. Every concussion, and I'm going to say this again, every concussion also has an element of whiplash to it. And this is where we're going to talk a little bit about the biomechanics. So concussion, in order to cause that amount of stretching and shearing, remember that what you're looking at, concussion is just an ion exchange that happens. To get those cells to stretch enough to create those gaps in the cell body, to create that ion exchange, it requires 70 to 120 Gs. And people have probably heard me say this before, but just to put that in perspective, if you're in a car accident, your airbags are set to deploy at a change of velocity of 48 kilometers an hour or 30 miles an hour. So if you rear end somebody who's dead stopped and you're going either 50 kilometers an hour or 30 miles an hour, which is the same thing, and you hit somebody, your airbags will go off. Now, and various biomechanical studies have found that translates into about 60 Gs through the seatbelt. So you're talking about the amount of force required to cause a concussion injury is being 70 to 120 Gs. And when you look at football impacts and things like that, that's why not every hit causes a concussion injury. It's substantial. It requires a substantial amount of force to cause that concussion injury, 70 to 120 Gs. 77% of the injuries, 77% of the impacts in football are below 30 Gs. So concussion threshold impacts only happen in less than 1% of all kind of football collisions. Now, when we get into the neck, it only takes 4.5 Gs to cause mild strain injury of the cervical spine. So literally in every single concussion case, you're also going to get at least 4.5 Gs to the neck. So 70 to 120 Gs, there's no way you're not taking at least 4.5 Gs to the cervical spine. And that's enough to create cervical spine dysfunction, kind of that whiplash mechanism of injury. And the thing is, the symptoms of whiplash and the symptoms of concussion are identical. You cannot tell patients apart that have concussion and have whiplash. And here's just to show you. Concussion on the left, whiplash on the right. We have headaches, dizziness, balance problems, cognitive disturbances, memory, concentration impairments, visual disturbances, fatigue, psychological distress, all with concussion and all with whiplash. So here's some other ones just to kind of show you. Disturbances of cognitive and emotional functions in patients with whiplash. Sensory motor disturbances and neck disorders affecting postural stability, head and eye movement control. There's a lot of stuff coming out of Australia on this topic as well. Sensory motor function and dizziness in neck pain. Reduced cognitive function in a group of whiplash patients. This was actually my thesis that I did with John Letty and Barry Willer in Buffalo. And what we were looking at is comparing people with chronic concussion to those with chronic whiplash. And so when patients came in, we would give them we'd give them 2 sets of outcome measures. We'd give them 1 outcome measure for whiplash symptoms and 1 outcome measure for concussion symptoms. And after we collected a whole bunch of patient data, we looked back on it and we grouped them based on what their primary physician diagnosis was. So if the physician called it whiplash, they were in the whiplash group. If the physician thought they had a concussion, we put them in the concussion group. And we were looking at patients between 1 month and 1 year after injury, and they had to be suffering at least 3 ongoing symptoms, which is the ICD-10 criteria. And the outcomes we were looking at is the post-concussion symptom scale, which is from the SCAT, 22 symptoms rated 0 to 6. And then also the WAD Form C, which is from the Quebec Task Force, but it looks at whiplash symptoms rated from 0 to 4. And the results, we found a significant correlation between the post-concussion symptom scale and the WAD Form C in both the concussion group and the whiplash group. And we found no significant difference between either group on the post-concussion symptom scale and no significant difference between either group on the WAD Form C. And when we look at this is the people with concussion, this is the people with whiplash, and this is the WAD Form C. And we can see here neck and shoulder pain pretty much equal, decreased or painful neck movements almost equal, headaches higher in whiplash, dizziness and unsteadiness higher in whiplash, memory problems higher in whiplash, problems concentrating higher in whiplash, and low back pain higher in whiplash. Now when we look at the post-concussion symptom scale, pressure in the head higher in whiplash, nauseousness, dizziness, balance problems, feeling slowed down, fogginess, difficulty concentrating, difficulty remembering, and confusion, all higher in whiplash. And if we look at post-concussion symptom scale, post-concussion diagnosis, more emotional, irritable, and sadness. Only on the emotional side did the concussion group have slightly increased symptoms. So there's no difference between these 2 groups. And you can see here with whiplash, it causes basically the same types of symptoms. So just getting back to this, I just want one more point here. Are we looking at the symptoms of concussion? If we look at concussion as being kind of that 3 to 4 week timeline for a metabolic recovery, and if we look at whiplash recovery, it can take 6 months to a year. How many of these patients coming in years and years later aren't necessarily dealing with ongoing concussion issues, but they had a whiplash injury at the same time that nobody's bothered to kind of check into and treat, and so they keep kind of doing concussion stuff and giving them academic accommodations, and no one's really getting in there and able to figure out where these dysfunctions are and fix it, because if you do, oftentimes a lot of the headaches, dizziness, and stuff like that may get better. And we go into really, really great detail on this in other courses. So this is just kind of a cool slide because it shows a little bit of the pathway just for cervicogenic dizziness. If we think about cervicogenic dizziness, your eyes and your inner ears and your proprioceptive mechanisms in the muscles and joints of your body are what tell you where you are in space. The most highly dense areas for proprioceptive input are in your digits, meaning your fingers, and in your neck. So they've done studies on animals where if they would just inject anesthetic into nerves and muscles of an animal's neck, they can't walk properly. They miss objects when they're trying to grasp because their brain isn't getting all the necessary input it needs in order to make a proper decision. So your neck tells your brain a hell of a lot about where you are in space, and if there's dysfunction there, people are going to feel kind of that sense of dizziness. So let's think about it this way, right? The vestibular system has 3 systems working, and this is kind of what I said: neck, eyes, inner ears. And if all 3 systems are telling you the same thing, you're going to feel good. If your eyes and ears are telling you that everything is level, but your neck is telling you that everything is tilted because it's so tight on one side, your brain isn't going to know who to believe. And so oftentimes patients with post-concussion dizziness don't necessarily feel like they're dizzy. When you get them to describe dizzy, they say, well, no, like the room isn't spinning. I don't have that vertigo feeling. I just don't feel right. I just feel off. It's just like this slight feeling of feeling off. When they shoulder check in their car, they get this split second of kind of dizziness. And a lot of that could be vestibular, could be visual, but it also could be neck. And I think that's something that gets missed a lot of the time. Consider the train scenario, and everyone's had this happening when you're sitting in traffic and a car beside you starts to move. You think that you're moving. You have that split second of discomfort where you kind of, oh my God, you slam on the brakes maybe of your own car, or if you're sitting on a train and the train beside you starts to move, you feel like your train is the one moving. And it just gives you that quick split second feeling of just not being quite comfortable. You kind of grab onto the seat a little bit. The neck is also rich in Golgi tendon organs and muscle spindles. So here's those studies I was talking about. Experimental animals staggered and were disoriented after cervical spine muscles were damaged. Abrams did a section of neck muscle nerves in cats, and it resulted in tremendous postural disturbances. So check this one out. In the early stages of recovery, cats adopt an awkward, broad-based posture and show reluctance to walk. Over the next few days, they exhibit consistent problems of ataxia, in which the hind limbs do not always step in time with the forelimbs. Animals tend to fall over when attempting turns and often avoid the falls by walking close to walls. Right? And we all know how good cats are with their proprioceptive processes and balance, and yet they can't even walk if some of the muscles and nerves of their neck are damaged. Same thing with monkeys. Monkeys whose dorsal roots were anesthetized have similar deficits, affect orientation and motor activity of the whole body, have difficulties in reaching and grasping objects they are looking at, and they often miss. This suggests a mismatch between visual and proprioceptive cues about the position of the body in space. And not even to mention, when you start talking about cervical referral patterns into the head, I'm sure most therapists have seen these types of images. Various muscles in the neck, various joints in the neck will refer pain into the head. So a lot of patients that have these, frontal headaches, oftentimes it just requires a little bit of tissue work to clear it up, but it also could be all these other issues as well. Theory number 5, the psychological. There is a large degree of psychological overlay in every single concussion case. Pre-existing psychological disturbances such as depression and anxiety increase the risk of developing post-concussion symptoms. So if they already have these conditions, that's a red flag. Make sure you give them a lot of education when you first see them. I put infinity here because I couldn't even fit them all in one slide if I tried. There are so many studies that demonstrate how depression and anxiety in the pre-existing state will promote the development of post-concussion symptoms. Cognitive complaints are also very subjective. So there's a thing called the good old days bias. I just did a post on this with my Instagram, I believe yesterday. And patients, what the good old days bias is patients with concussions will often rate their pre-injury status as being superior to that of people in the general population. So oftentimes they may be trying to achieve an ideal recovery pattern that's actually not possible, because they can't remember what normal is like, and they feel like they'll often say things like, this never used to happen to me before, or I used to have the best memory, or any one of the following, because they're trying to get back to what they believe that they were, even though it may not actually be how good they were. So there's a few studies on this. This one here looked at concussion patients versus orthopedic injuries, and they asked each group to rate their symptoms on a post-concussion symptom scale as to how they think they were before their injury. And when they asked the orthopedic group, if they had high post-injury symptoms, they would also rate their pre-injury symptoms as fairly high. However, in the concussion group, when they had high post-injury symptoms, they rated their pre-injury symptoms as very low. So that's the bias, where patients often with persistent concussion symptoms will rate or believe that their pre-injury status was far superior to what it is either now or even to that of the general population. Here's another study here that compared concussion group with patients of the general population, so healthy, uninjured control group. And they asked the healthy group to fill out the post-concussion symptom scale as they currently are. Right now, how do you feel? And then the concussion group, they asked them to fill it out as they believe they were 2 weeks before their injury. And what they found is that the concussed group reported their pre-injury status as far superior to that of a normal, healthy adult. So they were rating their pre-injury status as zeros across the board, whereas most patients are going to, say I have a bit of a headache, etc. So even healthy people will endorse some symptoms that look like concussion, but concussion patients will often rate their pre-injury status as 0 all across the board. And this is starting to show up as well in the CTE side of things. So CTE is the chronic neurodegenerative condition that happens in former football players, and they believe it's due to concussion or even just head trauma in general. And what we're finding, and also the people in Buffalo found this as well, is that when they actually test these people, so they're coming in saying they have neurocognitive complaints, they have memory impairments, they're not as sharp as they used to be. Even sometimes their spouses will say that they have, memory dysfunction, and their memory is slipping and yada, yada, yada. But when they actually test them, oftentimes they test within the range of normal for neurocognitive function. So here's a study that was done in Toronto. Ex-NHL players show no significant cognitive impairment regardless of how many concussions they'd suffered. The findings don't match how some players say they feel. But if you can imagine you're a former player listening to the media reports and just believing and thinking that, oh my God, I had a couple concussions in my career, and starting to then focus on everything that happens in your life. And if you do something like misplace a cell phone, forget to call a friend, forget someone's birthday, you're immediately going to think that there's something wrong with you cognitively, and it's going to create this downward spiral where just because you're thinking about and focusing on it, you're not going to be able to have good cognitive function because you're distracted with those thoughts. And so we have to be very cognizant of what these headlines are doing to former athletes, and being able to provide them with education on this research really helps patients out in terms of having that kind of good recovery, easing their mind a little bit. And this is also how psych gets into the cognitive function. So depression on its own has been correlated with worse neurocognitive performance. It's been correlated with worse reaction time. There's also a concept called cognophobia, where concussion patients believe that if they do something, that their symptoms will get worse, and so therefore they avoid doing anything. And that actually just makes them worse and worse and worse because they're not using their brain. And so it's kind of a use it or lose it concept, where because they're afraid to read, they don't read because they're worried that it'll make their symptoms worse. So they become afraid of reading, or they become afraid of screens. And because they're avoiding it so much, going back to it becomes more and more and more and more difficult with each passing day. So we have to understand that this is a major issue with concussion patients, and having a lot of education in this area and becoming an expert in this area will help your patients to recover just by providing them with appropriate educational tools. So the three main brain networks for cognition, we have the default mode network. This is kind of your day-to-day thoughts, just kind of when you're kind of letting your mind wander about, what I have to get for groceries, etc., etc. Then you have your executive network when you're focusing on a task. So this is if you were doing an exam or really dialed into something. Your executive network is the one that's working. Then you have the salience network, which just allows you to switch back and forth between the two networks. And what they find is that most of the time we're in the default mode network. Most humans walk around kind of in the default mode network, kind of daydreaming a little bit, unless you're actively doing something. And people, you can think about this when you're driving somewhere. So when you're driving somewhere, and have you ever driven somewhere for an hour or 2 hours, and all of a sudden you get there and you don't remember how you got there, and you've just kind of been driving with your mind shut off? It's because your mind was on default mode network, and you weren't really in the executive network. Now, in healthy brains, most of the time the default mode network is active. However, what they found in concussion patients is that they can't shut off the default mode network when they're trying to focus in the executive network. So when you give them a task, the default mode network doesn't shut down. And so what they end up with is they're not able to function as good on the executive task, the task at hand, because their default mode network is getting in the way. But also, and this is called default mode interference, but also what this does is creates a huge energy demand on the brain because they're using more of their brain to try and achieve the same task. And this is where you get people with this cognitive fatigue, where a concussion patient will do kind of a seemingly mundane task and then start to feel very, very fatigued as the day goes on. And that's what is a default mode network. But the thing is, this is no different than people that have long-term stress or people that have anxiety. So there's ways that you can cope with these two conditions that allow people with concussion to benefit from that. And mindfulness and things like that, breathing exercises sometimes, or even just the education helps patients to focus a little bit better and channel their energy a little bit better. So that's all we're going to talk about for today. Here's the main takeaways that I want to give you guys. We need objective measures for return to play, and it needs to be multimodal, okay? If you're doing neurocognitive testing now, let's keep neurocognitive testing, but shift towards a more comprehensive approach. We need to have that multidimensional. Make sure you're incorporating exertional tests following the injury before you make a return to play decision. I think we'll have sports be a lot safer, and we'll start to see less of the chronic neurodegenerative stuff happen if we were to go this way. Acute injury, really all you want to be doing, you're ruling out red flags. You're looking to see, do they need to go to the hospital? Do they need a CT scan? always, if you are in doubt, send them. It's always better to err on the side of caution and send them to the hospital if you're unsure. And then it's just managing symptoms. So once you've ruled out the red flags, you've done your kind of cranial nerve, cerebellar testing, make sure that there's no serious brain issues. Then you're just going into managing symptoms, walking them through the return to learn, return to work, or return to play steps to get them back into their regular life. If they have symptoms lasting any more than 10 days, you need to initiate rehab. But you need to know where to start for this. So there's a specific progression in terms of how and when to do this stuff. So if you are going to be treating concussions, make sure you get some additional training in how to kind of bring all that stuff together. Obviously, this is nowhere near enough, but I wanted to give you guys an idea of just the evidence that's out there around therapy-based interventions for concussion patients, because this is a huge area and I don't think enough therapists are taking advantage of this area. The role of therapists is significant. I just said that. If you're going to be managing concussions, make sure you do get additional training. How do you determine if a continuing education course is good? First of all, make sure it's multifaceted in terms of its rehab. Don't just take a vestibular course and think that can be applied to concussion, because like I said, only, that one study, only 46% of patients had a vestibular issue, but 100% had a visual issue. So if you're not trained on that, tying that all together, make sure it's a course specific to concussion, not just one facet of that concussion, because otherwise you're not going to be able to have the success that you should in order to generate the referrals and help the amount of people that you're going to want to help with this. Ongoing updates on research, I think it's huge. Taking a course and walking away for a lot of things is okay, but with concussion, there's over 100 studies a month published on concussion, and so we're learning this stuff at such a rapid rate that anything you learned last year is pretty much out of date, by the time you actually get into it. So make sure that you have some way of continuing your education as you move forward in this. This is just kind of a little plug on our course. This is what we do in our course for those that are interested. It's 12 modules, it's 35 hours, and it goes in depth on everything from pathophysiology, all the mechanisms behind blood flow, pharmaceutical and natural interventions, biomechanics of injury, baseline testing, battery, impact administration, etc., assessment, management, pathophysiology for post-concussion syndrome, and then assessment and treatment for post-concussion syndrome, including all the kind of how-tos, where to look, how to do, what are the dysfunctions, treatment protocols, etc., that are all based on the evidence. And this was developed by our medical advisory board, so it's very comprehensive in terms of the amount of information that you're going to get in that. And we're also in the process right now of setting up a network, worldwide kind of global clinical network of trained therapists. And it's really just like great strength in numbers, because when you have this many clinics together, all kind of providing that evidence-based standard approach, we become the go-to area to go. We started in Canada. We have about 200 clinics now in Canada. We are just moving into the United States and Australia now, and we are kind of connected through this EMR system that allows athletes to move country to country, city to city, state to state, and get consistent evidence-based care. And it's really an advantage to have your clinic set up with that type of kind of branding and network around it. So anyone who's interested in kind of furthering your knowledge with concussion, anyone's interested in getting into concussion treatment, you can either reply to one of the emails you got to sign up for this webinar specifically. You can also email Kyle Reedhead. He's our program development manager from a global standpoint. His email is kreedhead@completeconcussions. You can find me on @concussiondoc on Instagram, concussion_doc. I'm always posting updates on research studies, treatment videos, all sorts of interesting stuff. And be sure to follow us @completeconcussions on Instagram, also on Twitter, and on our Facebook channel. So again, thank you guys for listening. I really hope that you learned a lot on this. I really hope that I piqued your interest in the concussion space. I think as therapists, we have such a tremendous gift to be able to give to patients, be able to help a lot of people. And I really hope that you make this part of your practice. So everyone enjoy the rest of your Sunday night, and thank you for taking the time out to share it with us.